Great, thanks, Samson. Yeah, it's an absolute pleasure to be here today. And congratulations, Samson, on sort of organising something that seems like a really, really great platform for critical care echo education, something that I think can be quite hard. So it's really great to link with people nationally. So well done on that.
Thank you.
When Samson asked me to do this talk, I was really happy to, talk about left atrial pressure. That was until I saw the timetable of people who I'll be following and people who will be following me, and my inner imposter syndrome definitely started creeping up. But anyhow, I'm going to be talking about left atrial pressure today, which I think is a really, really important thing, and probably one of the most important ones beyond your focused echo, after things like cardiac output monitoring. I think left atrial pressure is right up there with sort of utility in critical care. So what I'm going to be focusing on is the FUSIC HD protocol, and there's a reason for that. It's quite a simple protocol to follow. I think Ashley and Marcus have done an excellent job on making that very accessible and very pragmatic protocol for assessment of left atrial pressure. I will talk about some of the non-FUSIC HD parameters, but my focus will be on some of the FUSIC HD ones. I'll touch on some special considerations, some tips about assessing left atrial pressure, and we'll end with one case. So to start with, a question, I suppose this seems quite simple, and I guess it is, but I think it's important to know what we mean by left atrial pressure, and probably more importantly, what we mean that it isn't. So left atrial pressure is the mean pressure within the left atrium, and I suppose things that it's not is necessarily things like diastolic dysfunction. So I think we need to see these as two separate entities. Diastolic dysfunction is very important, and obviously it's very linked with left atrial pressure, but it's a chronic progressive disease of increasing stiffness of the ventricle. And this is very different from left atrial pressure, which can change quite dynamically, particularly in critical care with things like acute severe pathologies. So again, probably a question that seems quite simple. Why do we care? I suppose an increasing left atrial pressure physiologically will increase the pressure within the pulmonary venous system and cause interstitial alveolar edema, which causes respiratory failure. And then you can have further downstream effects of that with RV dysfunction, and ultimately you can get venous congestion as well. Can you hear me, Samson? Yeah. Could just hear someone saying something in the background. I don't know if that was a question or not.
Yeah, no, we can hear you.
Okay,
and
good.
Everyone seems to be muted, so I can't really work out where the sound's coming from.
Okay, that's fine. That's fine. So the other thing, I suppose, I know I said diastolic dysfunction is different from left atrial pressure, but they are obviously linked. And when you look at some of the literature about LV function in critical care, you'll find that diastolic dysfunction is an independent predictor of mortality in critical care. Whereas when you look at things like LV systolic function, which we would, naturally think does affect mortality and morbidity, you actually find that it doesn't make a difference in the studies that have looked at it. So, left atrial pressure, diastolic dysfunction is something very important and something that we can do stuff about. So practical uses. So I suppose this is where it becomes useful. So there's several times that we can use assessment of left atrial pressure. One is that you can do it as a static parameter to see what the left atrial pressure is. I think more and more we're using it dynamically after therapies and before therapies. So one thing that's really useful for is weaning failure. So if someone is weaning off a ventilator but failing on spontaneous breathing trials with that change from positive pressure to negative pressure ventilation, assessing the left atrial pressure can be really useful, because it might be that they have raised left atrial pressure and they're just going into pulmonary edema with that change in ventilation. So that's something definitely we can do, and assessing that before and after those breathing trials. Other things is in acute valvular pathologies. So if you've got a prolapsed or flail leaflet of some sort in the left side of the heart, whether that's affecting your left atrial pressure, by assessing that can be incredibly useful. And again, in patients who've got pulmonary edema, who've got normal systolic function in your basic focused echo, you can assess the left atrial pressure to see if they've got heart failure with preserved ejection fraction that's actually causing pulmonary edema. And then you can obviously assess it dynamically pre and post fluid challenges as well. You can use it before giving fluid to see if you should be giving fluid and if it's safe to give fluids. And you can assess it after to see if the fluid has, made a good effect or a bad effect on the patient. So this is a very terrible drawing by me, but bear with me. This is just to explain very basically, physiologically, what happens and why it's important. And this might seem really simple, but I think it is really important to understand, and I hope that it'd be useful. So essentially, with raised left atrial pressure, your left atrium will typically dilate if it's a relatively chronic process and not suddenly very acute. That pressure in the left atrium will be transmitted into your pulmonary veins, causing an increase in your pulmonary vasculature. And then what happens is when you get to the alveolar surface at your pulmonary capillary bed, this will increase the pressure there, and this will cause interstitial alveolar edema, which obviously impairs gas exchange. So this is the FUSIC HD protocol. For anyone that's doing FUSIC HD, I'm sure this is a very familiar diagram. And I think this is a really great diagram. There's loads of different ways to assess left atrial pressure and diastolic dysfunction. I think this is one of the most pragmatic ones out there, and probably the only one that I've seen for critical care. Most of the other ones are in the outpatient cohort. So I'm going to be following this FUSIC HD protocol and just going a little bit more into detail in each of these parameters. So you can see right at the top here, we've got assessment of lung ultrasound to assess for B lines and then looking at the atrial septum. So this isn't a talk on lung ultrasound, and I'm sure all of you are very familiar with this, but essentially you're looking for B lines, which are these vertical artifacts, which are a sign of interstitial alveolar fluid or an air fluid interface. And in this instance, we're assuming this is cardiogenic pulmonary edema, but obviously there's loads of different reasons that you can have B lines and pleural effusions, but that's one thing to look at, and I think that's a really easy thing to look at. Next, we look at the interatrial septum. So again, a terrible drawing from me, but the interatrial septum, I think, is a really useful thing to look at. It's a thin membrane, obviously split in the atria, and naturally its position will change depending on the pressure within the right atrium and the left atrium. So what happens in a normal heart is in diastole, the interatrial septum is slightly bowed towards the right atrium, and then in systole, it moves towards the left atrium slightly. So again, what it does is this movement in systole and diastole. Now, what happens in raised left atrial pressure is that interatrial septum will start shifting towards the right atrium. So in normal or possibly raised left atrial pressure, you might see that interatrial septum as neutral, and then you'll start seeing it bowing more and more towards that right atrium, as evidenced here. And there's actually good evidence that show that the degree that it bows towards that right atrium is correlated with the amount numerically of the left atrial pressure. There's a few caveats to this. Obviously, if you've got a hole in your interatrial septum, that's going to be completely shifted. So if you've got a PFO or an ASD, forget about where the interatrial septum is bowing towards, because it's not going to be accurate. Similarly, if you've got someone with really raised right atrial pressure for whatever reason, your interatrial septum might be fixed towards the left side, even though your left atrial pressure is high as well. It's just obviously a pressure gradient. So if your right side is higher than your left, the interatrial septum will bow towards there. So it's quite a useful one if you've got a central lining, and you can see that the CVP is 6 millimeters per mercury, and then the interatrial septum is not bowed towards the right side, then you can assume that left atrial pressure is lower than that. So here's an example. Does anyone want to, I'm going to try and make this slightly interactive. Does anyone want to comment on this, unmute themselves and comment on this apical four-chamber view and the interatrial septum in particular? Can't see anyone's face, so it's going to be difficult.
So it looks like the interatrial septum is bowed over towards the right-hand side.
Yeah, great. Thank you for whoever that was that volunteered. Yeah, perfect. So the interatrial septum, you can see, is sort of, for the majority of the cardiac cycle, they're fixed towards the right side. So that's suggesting that the left atrial pressure is high. And you can probably sort of visually see that this left atrium just looks a bit dilated as well, volumetrically. Perfect. This is a QR code to an article about the interatrial septum and its relation to left atrial pressure, which is quite a nice read if anyone is interested. I'll leave that for 5 seconds just for people to scan if they want to. Cool. So we'll move on to the rest of the left atrial pressure assessment on the H2 protocol. Before we start that, I think it's really important to just talk about left ventricular diastole. And this is sort of very basic physiology, but I think it's important to understand and helps us understand mitral inflow Doppler, which is what we're going to talk about next. So in diastole, there's 4 phases, as you all know. There's isovolumetric relaxation. So this is at the point that the aortic valve and the mitral valve is closed. The ventricle is starting to relax after end systole, and the point that the ventricle relaxes and the left ventricular pressure decreases and equals the left atrial pressure. So that point before the mitral valve opens and filling starts, that's obviously isovolumetric relaxation. Next, you have your early ventricular filling. This is when the left ventricular pressure is now lower than the left atrial pressure. So the mitral valve opens and blood starts flowing through a pressure gradient from the left atrium to the left ventricle. And then what you have is a period of diastasis where the left atrial pressure and the left ventricular pressure are quite similar. So there's not a lot of blood flowing between the atria and the ventricles. And then finally, as you all know, there's an atrial kick in sinus rhythm where the atria contracts. And for a brief moment, the atrial pressure increases because of that contraction, allowing some blood to fill into the left ventricle. And if you put pulse wave Doppler at the mitral valve, this is what you see, and this is the trajectory of blood going into the left ventricle. And you see that there's a decent amount of blood that goes in early ventricular filling. You have this period of diastasis where there's no blood flow, and then an atrial kick. And those are your E and A waves, but we'll come to that. So this is what we're talking about in the FUSIC HD protocol, the next part. So assessing your E and A waves. And what we're most concerned about with this is the ratio between the E velocity and the A velocity. So the patterns of this, so in a normal E to A ratio is less than 2. So your E velocity and your A velocity, the ratio between them is less than 2. And this is a typical pattern of what you see. This is a real life example of an E to A ratio of less than 2, and this is a normal pattern. You can see that peak E velocity and the peak A velocity, the ratio of that gives you a ratio. And most machines will automatically calculate that once you sort of select those peaks of the E and A wave. And you can see there it's 1.18. So moving on, you get something called a impaired relaxation pattern, and this is where your E and A ratios are now inverted. So this is because the ventricle becomes impaired in its relaxation, so it slows down in its relaxation. That means in the early ventricular filling period, there's less blood that goes into the ventricle, and you get a reverse EA ratio. Now, this can be normal, particularly in patients that are above the age of 50. The predominant pattern, even in healthy patients, is that you've got a reversed EA ratio. And this does not necessarily mean you've got raised left atrial pressure. Following this, very confusingly, it goes back to what it was at the start. So this is called a pseudo-normal pattern. And this is where the ventricle now starts becoming a bit restricted, and the blood flow into the left ventricle is very sharp and sudden. And you get a pseudo-normal pattern where that ratio then goes again between 0.8 and 2. So just like the first one, this is where inflow can get quite confusing. And this is an example of a sort of pseudo-normal pattern. You can see that the ratio there is 1.8, which you can see how you can confuse that for just a completely normal pattern. And just looking at that, it's very, very difficult to say whether that's a normal pattern or a pseudo-normal pattern. There's a few things that you can look at. One thing is something called your mitral valve deceleration time. So you can probably see that from that, at the peak of the E velocity, there's a slope that's been drawn down to the baseline. And that's the slope, that's the mitral valve deceleration time. In pseudo-normal, that becomes shorter and shorter. And when you get significant raised left atrial pressure and restrictive filling pattern, that becomes very short. So that's one thing that you can look at. The other thing is if you've got a spontaneously breathing patient, that's an awake patient, you can do a Valsalva maneuver. And because of the changes in atrial pressure with the Valsalva maneuver, if someone had a pseudo-normal pattern, they would then go back into a impaired relaxation and their E to A ratio would flip, Whereas if they had a normal pattern, a Valsalva maneuver wouldn't change anything. So that's one thing to do, and it's definitely beyond the scope of FUSIC HD, but it's just one thing to bear in mind. And then with further increase in left atrial pressure, you get a restrictive fill-in pattern. This is much easier to sort of identify. You have an E to A ratio now that's more than 2. So you've got a very high E velocity and a very small A velocity. And this is called a restrictive fill-in pattern. And the left atrial pressure is assumed to be high in these cases. And you can see in this example, it's 3.7. So this is the sort of range of increasing left atrial pressure with your mitral inflow patterns. As you can see, it's not a linear change, and it can be really confusing to differentiate between the first three. If it's normal, you don't know if it's pseudo-normal. If it's reversed, you know what it is. And if it's restrictive, you know what it is. But the other two can be quite confusing. So this is an example of me doing mitral inflow on one of my colleagues. So you get an apical 4-chamber view, you put pulse wave Doppler at the tip of the mitral valve leaflets, and then you get this typical pattern. So you're looking at blood flow into the left ventricle, so it's all above the baseline, and you're looking for your E and A wave, which you can use using your ECG. Your E wave will obviously be before your A wave, and you're going to mark the peak E velocity, the peak A velocity, and most machines will make you mark the deceleration time as well. And you can see in this case it's 1.55, which is normal. So some tips about mitral inflow. One thing is in tachycardia, often you get a trace that looks like this. And this is because in tachycardia, your time in diastasis is shortened. So your E and A wave can often fuse together and overlap over each other. So you can never really do a ratio. What you can do with this is increase the sweep speed, and this will try and split these waves. So that's in some occasions, you'll be able to split the waves completely such that you can measure the velocity. So that's one trick that you can do in the instance of tachycardia. This is another sort of difficulty with inflow. So does someone want to comment on these images here? So top left is a left ventricular outflow tract zoomed image. The top right is a parasternal short axis image at the color at the aortic valve. And then the bottom image is a pulse wave Doppler at the descending thoracic aorta. Does someone want to comment what they think of these images together?
I mean, it looks like the patient would have probably significant aortic regurg.
Yeah, perfect. Yeah, so this is acute severe aortic regurgitation secondary to vegetation. So you can see there's a big vegetation on the left side with a big coarctation defect, a lot of regurg, and then the bottom image is just identifying hollow diastolic flow reversal in the descending aorta. So the reason I've put this on here is aortic regurgitation is actually an important one with mitral inflow, because it can really, if it's significant, can really mess up your inflow trace, because as you can imagine, blood is flowing there in diastole and can interfere with your E and A wave. So this is that same patient, and this is their inflow. And you can see there's no way you'd be able to measure an E and A ratio here, just because there's loads of artifact from all that blood coming back from the aortic regurgitation. So that's something to bear in mind. If it looks like that, think you might have some aortic regurgitation going on. Respiratory variation is really common. So you'll often see when you do mitral inflow Doppler that as the patient breathes, they'll flip from a normal pattern to an impaired relaxation pattern, and you never know when to really measure it. The sort of textbook definition of when to measure it is at end expiration. That's obviously very difficult with patients on ventilators when we're quite busy, but that is technically when you're supposed to measure it. So that's one thing to bear in mind. Another thing that I see, deceleration time is not on FUSIC HD, but when some people do measure deceleration time, they'll often only measure part of the E wave, but it's really important to know that you have to go right down to the baseline. It's a measure of time, and even if the E and A are slightly fused, as long as you can make out the slope, you continue that slope down to the baseline. Otherwise your time will be wrong. So we've spoken about B lines and interatrial septum. We've talked about mitral inflow. Now we're going to move on to the sort of the final three parameters that the FUSIC HD protocol talk about, which is your left atrial size, your TRV max, and your E to E prime. We're going to start talking about tissue Doppler first because it goes hand in hand with mitral valve inflow Doppler. So tissue Doppler is essentially, people get confused what tissue Doppler is. So it's essentially pulse wave Doppler. It's the same technology, but it's it's got different wall filters, and the speed, what you're looking at tissue Doppler is the excursion of myocardium. Whereas with pulse wave Doppler, looking at things like mitral inflow, you're looking at blood flow. So blood flow is obviously much higher and faster than tissue. So when you have pulse wave Doppler, you've got speeds in the meters per second, whereas with tissue Doppler, it's often in centimeters per second. So that's the main difference in tissue Doppler and pulse wave Doppler. And what we're doing with these is we're going to put tissue Doppler at the lateral mitral annulus and the medial mitral annulus. And you're essentially trying to see how much that basal segment is moving up and down. And for the purposes of diastolic dysfunction and left atrial pressure, we're looking at how much it's moving down when it's relaxing. And you get 3 waves with your tissue Doppler. One is your S prime, which is when the myocardium moves upwards, and that's in systole. And then you've got your E prime and then your A prime. So your E prime and A prime are essentially the same as your mitral inflow E and A wave. They're just flipped the other way, but they represent the same portion of the cardiac cycle, which is passive ventricular filling and your atrial kick. With tissue Doppler, as we say, we're looking at the movement of myocardium and the speed of movement. And these are representing the change in volume and the speed of change in volume in the ventricle, and hence a measure of left atrial pressure and diastolic function. So just to compare tissue Doppler and pulse wave Doppler, you can see this is mitral inflow on the right, and then tissue Doppler on the left. You can see that pulse wave Doppler is in meters per second, tissue Doppler is in centimeters per second. The wall filters are changed. So in pulse wave Doppler, you're often ignoring those very low speed velocities that might be represented by tissue movement. Whereas in tissue Doppler, that's obviously what we're after. Okay, so this is what you get with progressive increase in left atrial pressure. So you get your E prime value reducing as you get increasing left atrial pressure. And I think tissue Doppler, for several reasons, is really useful. One is that it is relatively independent of loading conditions, whereas mitral inflow Doppler is not. And it's also a lot simpler to follow because it's got a linear reduction in E prime values, and it doesn't have that reversal in E to A ratio like mitral valve inflow does. So this is what happens with increasing left atrial pressure. Your E prime values will reduce. It's important to note that the older you get, just naturally your E prime values will become lower as well. So when you look at things like the BSC guidelines, there'll be age-specific cutoffs for E prime values. So this is an example of tissue Doppler. So you can see here, we're putting it at the medial annulus, tissue Doppler's been applied, and then you're waiting for a nice trace where you see your S, E, and A. You can see it here. And for the purpose of left atrial pressure, we're just interested in the E prime value. For tissue Doppler, you want to kind of reduce the gain a little bit. So you're marking the brightest spot, which is a modal velocity, which you just saw there. And this is just going to repeat. Oh no, this is a lateral annulus now. And you can see again, you've got that nice S, E, and A. The gain's been reduced, and then the brightest part of the E wave is being marked, which is the modal velocity. So you want to try and ignore the fuzzy bits that represent artifact. So we've spoken about the mitral inflow Doppler and our E to A ratios, and we've spoken about tissue Doppler and our E prime. So what we do is we combine both of these. So you can see here is a medial E prime and a lateral E prime. You get the values of those E primes and you average it. So add them together and divide it by 2, and you get your mitral inflow E velocity. So we're interested in the peak E velocity. So in this instance, it looks like it's just under 1 meter per second. And then what you do is you do a ratio of your E velocity over your average E prime measurement. And this is a really useful value and one that's quoted everywhere in assessing left atrial pressure and diastolic function. It's really good when it's low. So if it's less than 8, there's high specificity that left atrial pressure is low. And if it's above 14 or 15, depending on where you look, there's high specificity that left atrial pressure is high. The issue is that in between grey zone of 8 to 14, where you can have a E to E prime of 10 or 12 and still have significantly raised left atrial pressure. So it's good when it's high, it's good when it's low. In the middle, it's hard to interpret. You can see in this instance, your E to E prime average is 15.8. Most machines will just average this out once you've done all those measurements. This is a QR code for a paper that discusses sort of the E to E prime value and its assessment in left atrial pressure for anyone that wants to have a read. That's another paper. I can't remember what that one is now, actually. I didn't know those two. So now we move on to tricuspid regurgitant velocity max. So I know there's a talk on pulmonary hypertension, and I'm not going to go into pulmonary hypertension in detail whatsoever. But the reason that we're looking at TRV max is because it's a surrogate for our pulmonary artery pressure, and we are interested in that because if you've got raised left atrial pressure, then that raised left atrial pressure can obviously cause a type of pulmonary hypertension. There's a lot of caveats with TRV max that we are assuming that the tricuspid regurgitant velocity max in this instance is caused by raised left atrial pressure. But we know, particularly in the intensive care unit, that there's loads of different reasons that we can get pulmonary hypertension. And this can include respiratory failure, which loads of our patients have, ARDS, pulmonary embolus, and positive pressure ventilation. So, I would take it with a pinch of salt, but it's definitely something that we need to look at. If you know someone's got pulmonary hypertension that's not because of left-sided heart disease, then you kind of essentially need to ignore this TRV max because it doesn't tie into your interpretation of whether a patient has high left atrial pressure or not, and it'll be due to a different type of pulmonary hypertension. As I said, this is not a talk on pulmonary hypertension, but there are a few ways to kind of try and differentiate between your pre-capillary pulmonary hypertension and your post-capillary pulmonary hypertension. And one of the easy ones is doing your right ventricular outflow Doppler and looking at your pulmonary valve acceleration time and mid-systolic notching, both of which would be a suggestive pre-capillary pulmonary hypertension. But I know that you've got a talk coming up on pulmonary hypertension, so I'm not going to sort of go into this in detail. And the cutoff for this, for TRV max for the Fusic HD protocol is 2.8 meters per second. Anything above that. Next is left atrial size. So the Fusic HD protocol has left atrial diameter, which I must admit I don't do frequently. I will usually be eyeballing the left atrial size or measuring it volumetrically in the apical 4 chamber plus or minus the apical 2 chamber, but this is a method to look at it, and I think it's a simple way to measure it. So essentially you're going to freeze it, and you're going to measure the sort of aortic valve level down to the mid area of the descending aorta. And the cutoff values for this is 45 millimeters and 50 millimeters, depending on gender, which would certainly suggest that it's significantly dilated left atrium. This is just an example of volumetric measuring it, which is a relatively easy way to do it as well, but is not within the Fusic HD protocol. And this is your apical 4 chamber and your apical 2 chamber. And you're measuring it when the atria are at its biggest. So atrial diastole. So sorry, I will take us back to the Fusic HD protocol. So we've spoken about all of these things, and I think when you start off doing this, it can seem a bit complicated, but actually, the HD protocol is relatively simplified, and I think it is a really good one. So I'm going to discuss a few of the non-Fusic HD parameters now that can be done, just to bear in mind. So pulmonary vein is one that's done frequently. With transthoracic echo, it can be really tricky getting a pulmonary vein Doppler. With TOE, it's a lot easier. But you can look at the pulmonary vein. Obviously, the pulmonary vein drains into the left atrium and can be a marker for left atrial pressure. So if you get a nice pulmonary vein Doppler, this is what it looks like. So you've got your systolic portion, which if you've got a really nice trace, is split into S1 and S2. Then you've got a diastolic portion, and then you've got an atrial reversal. So essentially in systole, as the atria elongates, the pressure in the left atrium reduces, so blood gets sucked from the pulmonary veins into the left atrium. Similarly, in diastole, as the mitral valve opens and blood goes from the left atrium to the left ventricle, pressure within the left atrium drops, so blood gets sucked back into the left atrium from the pulmonary vein. In your atrial kick, when the atria contracts, there is an increase in left atrial pressure, and you get this brief blood flow back into the pulmonary vasculature, and that's your atrial reversal. So with transthoracic echo, you very rarely see your S wave split into S1 and S2, and you very rarely see atrial reversal as well, just because the Doppler quality is not that good. What you get with your pulmonary Doppler can be quite confusing, and I think it's helpful to look at your mitral inflow ratios just to kind of orientate yourself. So in normal left atrial pressure, what you get is this bottom one, which is normal pulmonary vein Doppler. So your systolic and diastolic portions are usually similar. If anything, your systolic one is higher than your diastolic one. With impaired relaxation, because you've got that reduction in blood flow in your diastolic portion, you've got a reduction in blood flow in your diastolic portion of your pulmonary vein as well. So what you get is that your S becomes bigger than your D wave, and that's in impaired relaxation. But when you get increased left atrial pressure with more significant rises in left atrial pressure, you see that systolic portion getting blunted further and further. Much like Vexus for a lot, sorry, I'll go back to that. Much like Vexus, your systolic portion will just get further and further blunted. And when you get significantly raised left atrial pressure, you might even see systolic flow reversal. And you can see that with things like acute severe MR. So you can see that sort of systolic portion getting blunted further and further. But you can see again, it's almost like the inflow where it's not a linear change in Doppler profiles. So this is an example of pulmonary vein Doppler. So you get your apical four-chamber, and usually the pulmonary vein that you can get is your right upper pulmonary vein, which is just in this corner. You can adjust your scale on color Doppler to sort of identify more venous flow by reducing it to around 30 or 40. You can see it done here. And you can see just the flow of blood coming in there. And essentially you're trying to get your pulse wave gate 1 or 2 centimeters into that pulmonary vein. And often you can't really see it, but you get a trace. And you can see here there's decent S and D wave, and you can see that you can't see that S wave is split, and you can't see an atrial reversal, but you can see that the S wave is slightly bigger than the D wave, as it would be in normal health. So isovolemic relaxation time. I think this is probably one of the ones I use more outside of the FUSIC HT one. And essentially it's looking at the time in isovolemic relaxation. So again, this is the time where mitral valve and aortic valve are closed, the left ventricle is relaxing, and right up until the point that the mitral valve opens, when the left ventricular pressure becomes lower than the left atrial pressure. That's your relaxation time. So it makes sense if you've got really high left atrial pressure, then the left ventricle doesn't have to relax much and doesn't need to reduce its pressure much to be able to equal that left atrial pressure. So you can probably understand how your isovolemic relaxation time in really high left atrial pressure is going to be short. Again, the caveat to that is an impaired relaxation, because your left ventricle is impaired in its relaxation and taking a long time to relax. That isovolumetric relaxation time actually gets longer, so it can be a little bit confusing. Some ways to measure it: you can use tissue Doppler or continuous wave Doppler. So with our E prime measurement that we spoke earlier, this is the exact same wave. You can actually see your isovolumetric contraction time and your isovolumetric relaxation time, and some people measure it using this. So immediately after the S wave and before the E wave, so your heart's moved up and filling hasn't started yet, that's your isovolumetric relaxation time. So the normal range is between 60 to 110 milliseconds. So as I said, in abnormal impaired relaxation, that time becomes prolonged because the left ventricle is impaired in its relaxation, so it's taking longer to relax. But when it's restrictive and you've got really high raised left atrial pressure, the ventricle doesn't need to relax a lot at all until it equals the left atrial pressure, so that time becomes very short. I think this is where it's useful. If your isovolumetric relaxation time is less than 60 milliseconds, and that's a pretty good marker of raised left atrial pressure. And this is a paper that looks into isovolumetric relaxation time and its association with left atrial pressure. So this is just an example of me doing it. So as I said, you can use continuous wave Doppler or pulse wave Doppler. So here what's done is continuous wave Doppler is put right between the apical 4 chamber and the apical 5 chamber view. So you kind of get an in-between view. So you get your LVOT outflow as well as your mitral inflow. So you can see that this flow below, that's your LVOT, and the flow above is your E and A wave. And then if you increase the sweep speed, you want to try and find that zone between just after the LVOT outflow, just before the E wave. So the left ventricle, the aortic valve has sort of ejected all its blood, and it's just starting to relax, but blood hasn't started filling into the left ventricle. So that's that time that's been measured here. And that's your isovolumetry relaxation time. I think that's probably the best way to do it with sort of continuous wave Doppler, but some people use pulse wave Doppler as well at this stage. Finally, I'll just very briefly talk about this. This is not something that I do, and this is purely because this requires your atrial reversal and your pulmonary Doppler, and this is something that I think I get 1 in 20, 1 in 30 cases using transthoracic echo. So for me, it's just not a feasible one with transthoracic echo. But if you do get beautiful traces, it does make physiological sense. So this is your A time over your AR time, and we're essentially looking at a difference. So you're looking at the time taken in atrial reversal with your pulmonary venous Doppler. So you can imagine if your left atrial pressure is really high, when that left atrial contracts, the time where that blood flows reverse back into the pulmonary vein is going to be long compared to your A wave, which is where blood is flowing into the left ventricle from the left atrium. So you're essentially looking at the difference in these. And if it's anything less than 30 milliseconds, it's a sign of raised left atrial pressure. But as I say, you know, my knowledge on this is mainly based on textbooks. It's not clinical based because I don't use this clinically. And I think for transthoracic echo, it's not particularly useful, to be honest. Finally, I just wanted to touch on this. This is a patient with AF, and this is mitral inflow Doppler. I just wanted to put it to the audience. What do we think this wave here is after, you know, here? Does anyone want to comment what they think this might be? So just remember, this is a patient with AF. Any takers? If not, that's fine. So that's fine. So this is mitral inflow Doppler, and you can see this high velocity wave initially, which is your E wave, and you can see this little wave following that, which you could confuse for an A wave, but obviously in AF you don't have an A wave because you don't have an atrial kick, and this is actually something called an L wave. So this is something that you get where, particularly in atrial fibrillation, it's a sign of advanced diastolic dysfunction and raised left atrial pressure. And essentially, it's that time in diastasis where there's predominant filling into left ventricle, even after the early ventricular filling phase. And it's just a sign that the left atrial pressure is so high that even after that initial bit, blood is still flowing from the left atrium to the left ventricle through a pressure gradient. You usually see this with raised left atrial pressure, but you can see it in cases of bradycardia as well. And you can actually look at the velocity of this L wave as a marker of left atrial pressure as well. And this is in the new BSE guidelines. So anything higher than 20 centimeters per second is sort of a marker of raised left atrial pressure. And just to talk about fluid responsiveness and tolerance. So when do I think you should do it? So essentially, I think you use your multi-parametric assessment of left atrial pressure. And if that's saying that you think the left atrial pressure is low or normal, then, you know, you can likely give patients fluids and it's going to be fine. So that's the time to use it. And again, if your assessments suggest that the left atrial pressure is high, then you're probably not going to give fluids. So, you know, you can use this as a static parameter to say, actually, I'm not going to give this patient fluids. The risks outweigh the benefits. And obviously, you can use it dynamically, pre and post fluid challenge, whether that's a deliberate fluid challenge or a passive leg raise. And I would concentrate with these because you're obviously not going to be doing all these parameters before and after. You know, you're not going to be doing pulmonary vein Doppler and all these things. The things that I think are important are doing your E to E prime, you're looking at your interatrial septum visually and doing lung ultrasound. Those are the most feasible ones, I think, and the most useful ones, and ones that are all in the FUSIC HD protocol. So you can do this before and after and see what the changes are. Just to touch on AF, which makes a lot of advanced echo stuff difficult. The guidance is to take an average of a few measurements. So depends what textbook you read. It could be 3, could be 5, could be 15. So you have to take a few measurements and average it out. The atria will be invariably large in AF if it's chronic AF from chronically raised left atrial pressure. So that's to bear in mind. In atrial fibrillation, your lateral E prime is not that accurate. So in terms of tissue Doppler, you want to use your septal E prime average. And generally we say an E to E prime of septal more than 11 in atrial fibrillation is highly specific for raised left atrial pressure. And another thing that you can look at with your mitral inflow is if your E wave velocity over a slow sweep speed doesn't actually vary a lot beat to beat, then that in itself is suggestive of raised left atrial pressure. And obviously we spoke about L waves, which particularly in AF are a marker of advanced diastolic dysfunction with raised left atrial pressure. This article, this QR code is linked to an article about atrial fibrillation and assessment of left atrial pressure in it. So a few special cases. So I've already spoken about AF. Regional wall motion abnormalities are an important one. If you've got basal regional wall motion abnormalities, your tissue Doppler, because you're looking at that basal segment, is not going to be accurate. So if you've got basal regional wall motion abnormalities, essentially you have to ignore your tissue Doppler. So your lateral E prime, you've got to ignore it. And then things with the mitral valve really mess up your mitral inflow Doppler, as you would imagine. So with mitral stenosis, your E wave velocity is limited by your orifice area of the mitral valve rather than the left atrial pressure. And similarly with mitral regurg, your inflow velocities are going to be way off. So essentially you've got to take it with a pinch of salt with these. Similarly, if you've got mitral annular calcification, a little bit like regional wall motion abnormalities, when you've got that calcification in those sort of mitral annulus, that's going to significantly restrict the motion in the sort of septal and lateral segments, and that means that your tissue Doppler is again going to be inaccurate. And just to touch on young athletes, so they can be really tricky. So your left atrium can be dilated in fit and young healthy athletes. Other things that you can get is restrictive filling patterns. So you might see an E to A ratio of more than 2 in young fit people, and that can be normal. An important thing though is your E prime measurement should be very high. So your E to E prime measurement should be low in young athletes. So I've spoken about quite a few measures beyond FUSIC HD, but there's even more, and I'm not going to go into these. There's things like EPLAR, left atrial strain, which is the new BSC guidelines, L wave velocity, left atrial expansion index, and propagation velocity. You know, all of these have some part to play, but I think concentrating on those huge HD protocol is the most important thing, because they are covering the important markers of left atrial pressure that's in most guidelines. And what's different about the FUSIC HD one, I suppose, is it's combining lung ultrasound as well, which obviously cardiology guidelines won't necessarily. So just a quick case, and this is a chap that came to ICU with known LV dysfunction, with an EF of 30% previously, suspected pyelonephritis. He had a litre of fluid in resus, but he remained hypotensive. So this is his echo. Does someone want to comment on this echo just generally, and then about left atrial pressure, what they think in terms of visually?
It looks like an impaired LV with a visually dilated left atrium as well.
Yeah, cool. Yeah. So yeah, clearly an impaired LV with a dilated left atrium. So you're already getting signs that maybe left atrium is the left atrial pressure is high. So your left atrium, for anyone that watches Echo and they describe the left atrium, left atrial volume as the HbA1c of the left atrium, and that's because the left atrium dilates chronically and dilates with increasing left atrial pressure. Important to note, in acute situations, your left atrium won't dilate. It usually takes 2 or 3 days. And then again, just moving on from that, this is your sort of multi-parametric assessment of left atrial pressure. Does anyone want to comment on these? So we've got inflow, left atrial volume, TLV max, and tissue Doppler. And actually the screen is really small, so I think I've got a summary of the measurements. Yeah.
Seems that E to E prime is quite high, 15 here.
Mm-hmm.
And the LAVI, the left atrium volume index, it seems to be increased as well as 97 or something like this.
Mm-hmm. Yeah.
So yeah, significant left atrial pressure is high. Yeah.
Yeah, awesome. Yeah, so you can see there's a few things there. So your E to A ratio is more than 2. So that's a straight off the bat, that's a restrictive filling pattern. So if you use your Fusic HG protocol, assuming that there was no B lines on the ultrasound, you know, your E to A ratio is more than 2. If they're over 40 and they're not hyperdynamic, that's already, you know, you don't necessarily need to do the rest of the parameters. But you can see all the other 3 parameters of left atrial size, TLV max, and E to E prime are all high risk. So they've got 3 high risk features. So the left atrial pressure is probably high. So that's just a case example of sort of assessing left atrial pressure using the Fusic HG protocol. So that patient, you know, concluded that their left atrial pressure is likely high, fluids likely to cause harm. So they were admitted to ICU for vasopressors, and fluid responsiveness was importantly not tested because they're likely to be fluid intolerant. So that's essentially it. Thank you very much. It's been a pleasure to talk about left atrial pressure. There's a few articles here that I've linked. So the first one, bedside assessment of left atrial pressure in critically ill, is one that Emma Bocock's written, which is written really well. It's a really good read. So I'd highly recommend reading that regarding the assessment of left atrial pressure. And it's very specific to critical care, which I think is important because we see a lot of literature around diastolic dysfunction, but you know, the evidence for critically ill is sparse. So that's a nice article that discusses it. The middle one is the link to the new BSE guidelines, which I think is really well written, and it's a good read, even just for the physiology of diastolic dysfunction and raised left atrial pressure. And then the final one is a shameless plug to Orca, which is a resource that myself and a few colleagues have set up. It's a online radiology resource for critical and acute care, which includes a lot of point of care ultrasound, of which part of which is focused echo all the way to kind of intermediate and advanced echo with sort of interactive modules and videos, which is all free. So feel free to sign up. And that's it. Thank you very much. I'm happy to answer any questions.